I'm Elaine Peskind. I am a geriatric psychiatrist, and I've been doing Alzheimer's research for roughly 40 years. I served as the associate director and the director of the clinical core of the Alzheimer's Center for 15 years. And I've been the site PI for many, many clinical trials, and really almost all sorts of, Alzheimer's pharmacotherapeutic strategies. I think a total about 40 by now. We'll talk about our experience and just the state of the art of the field here. And I wanted to show you the two pictures that tell 1,000 words. These slides are from Tom Bird, and these are two people. This is the first of two who died in their, mid to late 70s. This is a cognitively normal person. So this is what a brain should look like. It's the coronal section. Right about through this plane. And this is what a brain should look like when you die in your mid-70s if you're cognitively normal. And the next slide is a person who died at the same age in the late stages of Alzheimer's disease. So this really gives you the graphic picture of what we're trying to prevent, really. And how maybe trying to reverse Alzheimer's disease may not be a viable strategy. And first, I wanted to just give you the background of what the FDA-approved pharmacotherapeutics for Alzheimer's are. So they consist of the cholinesterase inhibitors, and how they work is by increasing acetylcholine in the synapse. And this is all based on the severe loss of cholinergic neurons and the nucleus basalis in the basal forebrain, and reductions in the synthetic enzyme for acetylcholine. And there are technically four, but one is no longer used, Tacrin. So there are three drugs that are in common use, donepezil, galantamine, and rivastigmine. You can see their label indications. So, and they range from, some of them, the full range of Alzheimer's disease, clinically expressed disease, to rivastigmine, which is approved for mild to moderate Alzheimer's, and also for Parkinson's disease dementia. And they all work by the same mechanism. They have a little bit different side effect profiles. And memantine is, not in that same group of drugs. It's a low to moderate affinity, voltage dependent NMDA receptor antagonist, and it is approved for moderate to severe AD. And then the combination of the two, and there's a single brand name drug, Namzaric, and that is approved for moderate to severe AD. And let me give you just a little bit of the history of our experience with cholinesterase inhibitors. We were a site for the very, very first trial of Tacrin. And to get randomized in that study, you had to have had they did a run-in where they had increasing doses, and you had to have a best dose. You actually had to have a response to get randomized to active drug or placebo. We had 26 people who entered the trial. Only 3 of those 26 had a best dose. So that was problem number one. And then and then in the trial, we had people get, about half of the people that we entered into the trial got hepatotoxicity from Tacrin, including one who got very sick and had to be hospitalized for toxic hepatitis with, LFTs in the 1,500 range. So that was really a pretty dismal experience. And the other, interesting anecdote is that one of our 26 was Janet Adkins, and there's a reason I can use her actual name without, having a HIPAA violation. And that is because she was Dr. Kevorkian's first, quote, patient. So she was a person with very mild stage Alzheimer's disease with a mini-mental state of about 25. She was in her early 50s. I think she's the only clinical trials patient we had that wasn't postmenopausal. And she didn't have a first dose. She was very discouraged. Their family had been longtime members of the Hemlock Society, and she really, really wanted to commit suicide before she felt she was unable to plan and carry out a suicide. And the day before she flew to Michigan to be, quote, suicided by Dr. Kevorkian. She played a tennis match with her 35-year-old son and beat him. She was still able to play the piano. She had grandchildren. And it was a pretty horrible experience for us as her doctors. And Dr. Raskin had to go to Michigan to testify in Dr. Kevorkian's murder trial. So it was pretty horrible. So we came into this with a pretty dismal view of cholinesterase inhibitors, but then Aricept was approved. And I started using it. The data looked pretty good. We were aside for the clinical trials. And I've really been turned into a big advocate for treating Alzheimer's disease with our available drugs, because we were a particularly Alzheimer's genetics focused center. And so I was taking care of people in families with PS1 mutations and PS2 mutations, where I had cared for an older sibling in the era before cholinesterase inhibitors, and then a younger sibling in the era since. And I really saw in my own practice, patients do a lot better in terms of slowing progression. I had a real standout case who was in the year he turned 30, he got Alzheimer's disease. His father dead at 41 and his sister dead at 37, both having had about a 3-year course from onset of symptoms until death. And he ended up having a 13-year course. So to me, it was a real difference. And it was more than one family like this. So I became a real advocate, and I remain an advocate. And just to give you an idea what the data look like, these are data from the double-blind trial of galantamine, cholinesterase inhibitor, as we've been talking. And the 3 lines are, so the first 6 months were a standard double-blind parallel design, randomized controlled trial. And then the second 6 months, from months 6 to 12, were open label. So whatever you got in the first 6 months, the second 6 months, everybody got galantamine. And the 3 lines, the pink line are people who started on galantamine and then continued on galantamine. And of course, this is all double-blind until the open label part. The yellow line is people who were started on placebo and at 6 months went on galantamine. The green line is not from this study. It's a 12-month placebo group from a previous trial of another drug, actually a cholinergic drug. So it just gives you the idea in a placebo group for 12 months what people look like. And you can see that in the continuous 12 months of active galantamine, people, they do better in the beginning, then they kind of start fading off, but they remain at or above baseline the entire 12 months. Normally on the ADAX cog, you can see from the green, total placebo, group, that you expect about a 6-point decline on the Alzheimer's disease assessment scale, cognitive subscale. And that there was no decline in the active galantamine group over a 12-month period. And interestingly, they say this is symptomatic treatment, but look at the people who started off on placebo and then they went on to galantamine. They never quite catch up to the group that was on galantamine continuously. And that implies that there is some disease-modifying effect of cholinesterase inhibitors. So just, keep that in your back pocket. And then, I subscribed to Time Magazine, and I got this Time Magazine in the mail. Notice the date, 2010, and I was reading. I was really excited. I opened the, I hadn't heard about this. So, alas, some progress against the most stubborn disease, Alzheimer's. And I said, basically, what? And now I'll tell you the story. So a bunch of things have been studied in clinical trials, mostly by the Alzheimer's Disease Cooperative Study. So these are treatments that were suggested from epidemiologic evidence showing that there was an association between a number of these things and reduced risk of Alzheimer's disease. And so then they did clinical trials. So estrogen replacement therapy, that was negative. Anti-inflammatories, both standard NSAIDs and the newer NSAIDs, as well as prednisone, the ultimate anti-inflammatory, those were all negative. Ginkgo biloba showed no effect for prevention. Lowering homocysteine with folate, B12, and B6 was negative. The DHA, the active ingredient in fish oil, that was negative. And then resveratrol, that the potent antioxidant derived from grapeskins, that study was negative. So none of the things that have shown sort of epidemiologic association evidence with lowering risk of Alzheimer's disease had any effect either for prevention or for treating Alzheimer's disease. I would say the jury is still out on antioxidant cocktails. I don't think there's been a lot of attention to it lately. And then Brian has pretty much presented the entire story of the first actual vaccination, active vaccination with amyloid. And first of all, what you didn't cover, Brian, was that there was a relatively poor immune response with only 20% of people developing immunity. And then as Brian said, there was occurrence of autoimmune T-cell mediated meningoencephalitis as an adverse event with very bad clinical outcomes, and the trial was stopped. Since then, there have been basically every possibility of how you could either prevent the production of amyloid or remove amyloid is what we're going to go into now. So they've tried every possible mechanism for doing that. First, we're going to talk about the monoclonal antibodies in a few minutes, but first the gamma secretase inhibitors. So, and again, the Lilly gamma secretase inhibitor, it had a lot of adverse events, vasogenic edema, increased incidence of skin cancer, and worse, a dose-dependent worsening of cognitive function rather than improvement or stabilization of cognitive function. The RAGE inhibitor, which reduces amyloid aggregation in the mouse model, that study was stopped for futility. So with an interim analysis, it didn't work. Skyloinositol, which reduces amyloid aggregation again in the mouse model. The first phase 3 study was negative, so there was no further development. The beta secretase inhibitor, there have been a series of them, and the last standing BACE inhibitor, L-basistat, was discontinued again for safety reasons. And then all the passive immunization studies. So these are studies in which patients are either usually infused or injected with prefab anti-amyloid antibodies. This is a strategy that's been used in many diseases, many autoimmune diseases and in cancers. And there are many anti-amyloid monoclonal antibodies by different pharma companies with multiple specific and very specific anti-amyloid targets, and we'll go through each of these. There's in terms of side effects, there's a low risk of infusion reaction or anaphylaxis. Those risks are very low. But there is a higher risk of getting vasogenic edema and microhemorrhages, especially in persons who have the apolipoprotein E4 allele. And there are many phase 1, 2, and 3 studies that either completed or underway. They've been done at all stages of disease, mild to moderate Alzheimer's, mild cognitive impairment, and then preclinical Alzheimer's disease. And we'll just go through some of the major anti-amyloid monoclonal antibodies. So bapineuzumab was the first. It targets fibrillar and soluble A-beta, and that program was discontinued for lack of efficacy. Crenezumab targets oligomeric and monomeric A-beta, and that the AD dementia program was discontinued, people who already have clinical disease. The Colombian presenilin-1 familial AD study continues. That hasn't been finished yet. Solanezumab targets monomeric A-beta. Its AD dementia program was discontinued for lack of efficacy. The DIAN-2 study, the US study in presenilin-1 preclinical, these are Alzheimer's mutation carriers, so we're still clinically, cognitively normal. And that was negative. one would have to assume that that's a reasonable model of Alzheimer's disease, and it was negative. And and the A4 secondary preclinical AD prevention study continues. So this is a study in persons who are over the age of 65, they're cognitively normal, but they have amyloid PET evidence of having amyloid deposition in the brain. And it's a very long-term study. It was lengthened to 4 years. The dose was quadrupled, and that continues. And gantenerumab targets aggregated A beta. Again, the dementia program was discontinued for lack of efficacy. It was also studied in DIAN-2, the presenilin-1 carriers, and it was negative. And the study for prodromal AD is not finished yet. Then one of the two of the newer drugs, BAN2401, which targets large soluble A beta protofibrils. This is now being studied along with A4 as a secondary prevention strategy for preclinical Alzheimer's disease. So these three studies, A4, A45, and A3, are all being done by the combination of the Alzheimer's Therapeutic Research Institute and the Alzheimer's Clinical Trials Consortium, both at USC. They're really the same thing, but the ACTC is the new iteration of it. And they're all, again, for preclinical Alzheimer's disease, so people who have evidence of amyloid on PET or CSF, biomarker evidence of having amyloid in their brain. A45 is for, persons over age of 65. A45 backs up a little early. It's pretty much almost the same study, but with a different monoclonal antibody. And the A3 is even sort of earlier. So their amyloid deposition on PET is even lower. So a lower SUVR for their amyloid on the PET. So, and these are huge studies. There are thousands of people each. And they continue. And A45 and A3 were supposed to have a gamma secretase component to them, which of course had to be abandoned when elenbecestat was discontinued. So they now have just more anti-amyloid antibody studies. Donanemab, and I have to do a disclaimer here because I am the chair of the Data Safety Monitoring Board for their phase 3 study, which is underway. So I can only talk about, obviously, publicly available information. Their phase 2 study in early Alzheimer's was modestly positive with about a 30% reduction in the rate of cognitive decline compared to placebo after 18 months. Now compare that to the cholinesterase inhibitors in which there was, no decline after, 12 months. So think about that that's a rather modest benefit. There is a high rate of vasogenic edema and microhemorrhages, and actually one person had a very bad outcome from that. Their phase 3 study is underway, and its target is amyloid deposited in plaques. And so the bottom line about the monoclonal antibody studies that target amyloid, and as you can see, multiple ways, almost of all have very good target engagement. So just like Brian showed for the vaccine, where really, amyloid really does go away, these drugs are effective at removing amyloid. But despite this, there is very unimpressive, if any, benefit in treating clinical Alzheimer's disease. As I've described, the field is moving to earlier and earlier preclinical treatments. And these, even the preclinical studies are secondary prevention. These are people who already have the disease process. They have evidence of having amyloid in their brain. The risk of adverse events is not negligible. So these are cognitively normal persons. And we're talking about if a drug is approved for, say, early pre-symptomatic preclinical Alzheimer's disease, you're talking about basically millions of people who are cognitively normal, who don't have a clinical disease yet. So the risk of adverse events, the risk-benefit ratio becomes very much more important. And if they were approved, you know, these drugs that may have a modest benefit, they would be very expensive and healthcare resource intensive. Most of these are monthly infusions, so we're talking infusion center drugs. And to compare costs for other diseases that are responsive to monoclonal antibody therapy, psoriasis, rheumatoid arthritis, multiple sclerosis, cancer, those drugs range from, at the very least, about $20,000 a year to well over $100,000 a year. So you can sort of imagine what the impact on the healthcare system would be. And even now, the cost of, you know, globally for monoclonal antibody treatments in the US is expected to reach $160 billion per year in the next few years. So, you know, Brian talked a lot about, you know, how he feels about anti-amyloid therapies. I think this slide tells it all. You know, Risa Sperling, who is the PI of all three of the big time secondary prevention trials, she is a believer. She believes that, that amyloid gets to a certain level of deposition and then triggers what she calls the catastrophe, in which the tau now becomes the major player. But she really thinks that removing amyloid will prevent this. She is a true believer, and she has had enormous influence in the field. And I think there are people who just want to believe. And so other non-anti-amyloid mechanisms of action, the drugs that have been tried, Dimebon was the presumed mechanism for that drug was improvement of mitochondrial function. They had 2 phase 3 studies, both of which were negative. Intravenous immunoglobulins, this is sort of a broad scale immune approach, which has all kinds of problems about, you know, supply and adverse events issues, but the study was negative, I would say, thank God. The nerve growth factor study was negative. Intranasal insulin and pioglitazone, both, you know, sort of you know, sort of the strategies reflecting the increased risk in persons who have type 2 diabetes, so, you know, in terms of insulin sensitivity, particularly in the brain, and both of those studies were negative. And then very, very recently, just a couple days ago, the results of the troriluzole study came out. This is a drug that enhances synaptic glutamate cycling. And so it improves the clearance of synaptic glutamate. They just, a couple days ago, they just reported their phase 2/3 study in approximately 300 participants, and it was negative. And so I'm going to end up with this slide, which I got from Alaheimer, which is, you know, the Alzheimer's Association's sort of informational site, that kind of summarizes the field of studies that are either been completed, have been discontinued, or are in progress. And you can see the targets are amyloid related, cholesterol related in some manner, cholinergic system, inflammation, metals, other neurotransmitters, and tau. So as you can see, there have been a total of hundreds of studies. There are 5 approved drugs, and they all are, they're either the cholinesterase inhibitors or memantine, the glutamate drug, the NMDA receptor antagonist. So this is the state of the field, and we're gonna, I'm sure, have a lively discussion.